Welcome to the March 2024 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, the Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, the Associate Director of Advocacy and Outreach for LACNETS.
Today's presentation is on TKIs, Tyrosine Kinase Inhibitors, and Neuroendocrine Tumors. A special thank you to our supporters, Ipsen, ITM, Cronetics, and Tercera. LACNETS stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS staff includes Lisa Yen and Heather Davis. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joyce Mbezi, and NET patient Mary Dunleavy, who has been living and thriving with NET for 18 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. I'm going to hand it over to Heather.
Thank you, Kavya. Our YouTube channel features over 300 videos and podcasts. Use our playlist to find webinars on PRRT, liver-directed therapy, clinical trials, imaging, nutrition, Theopera, and our annual conferences and patient stories. Follow LACNETS on social media. We are on Facebook, X, and Instagram with the handle @LACNETS. And be sure to add us to your safe sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it over to Lisa.
As a NET caregiver myself, I find it's important to stay informed and engaged about the latest in NET treatments and also clinical trials, because we understand that clinical trials pave the way for future treatments. It can be challenging to understand the various clinical trials available for neuroendocrine cancers. And to help with this, we created a clinical trials guide. It's an educational resource that features several key clinical trials for neuroendocrine cancers. You can browse the site by the type of neuroendocrine cancer, such as pancreatic NET, GI NET, lung NET, Theopera, or high-grade neuroendocrine carcinoma. And you can also browse by some of the types of treatments, such as PRRT. When you go to the individual trial, such as one of the alpha PRRT trials or the cabinet trial that will be discussed in today's presentation, you will find brief patient-friendly videos and updates or announcements on the progress of the trial. We hope our clinical trials guide can help you better understand NET clinical trials. It's my pleasure to introduce our speaker for today, Dr. Jennifer Chan. Dr. Chan is a medical oncologist from the Dana-Farber Cancer Institute in Boston, Massachusetts. She is a renowned NET expert who is deeply committed to NET research, in addition to her busy clinical practice caring for patients with neuroendocrine tumors and gastrointestinal cancers. Dr. Chan is the director of the program in neuroendocrine and carcinoid tumors and the clinical director for the Gastrointestinal Cancer Center at the Dana-Farber Brigham and Women's Cancer Center. She is the current vice president of the Medical Professional Society for NETs, called the North American Neuroendocrine Tumor Society, or NANETS. As this year's vice president, she will be the next president of NANETS, following the next annual symposium this fall. Dr. Chan is also a past chair of the NANETS Guidelines Committee. She serves on the National Comprehensive Center Network, NCCN, Neuroendocrine Tumors Guidelines Panel. And Dr. Chan is also a member of the Neuroendocrine Tumor Task Force of the National Cancer Institute. She has been the principal investigator of multiple clinical trials investigating novel therapies for neuroendocrine tumors and has been involved in studies examining factors associated with clinical outcomes in patients with neuroendocrine tumors. Many of you have seen our video interview with Dr. Jennifer Chan in Madrid last October after she shared the data from the cabinet trial, an important phase 3 trial that studied the use of one particular tyrosine kinase inhibitor, or TKI, called Cabozantinib for advanced neuroendocrine tumors. Dr. Chan was the principal investigator of this exciting study, and she dedicated a decade of work to it. We're really excited to have her with us today to share about this type of treatment and what it means for the neuroendocrine cancer community. Welcome, Dr. Chan.
Hi, everyone. My name is Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute in Boston, where I direct our program in neuroendocrine and carcinoid tumors. I'd like to start first by thanking the LACNETS organization for the invitation to speak to you today about tyrosine kinase inhibitors and their role in the treatment of neuroendocrine tumors. I also want to thank everybody for joining in today and for submitting questions in advance. I'm looking forward to the discussion that will follow and being able to answer some of those questions. This slide is a list of my disclosures. And on the next line, I've provided an outline of the topics that I'll cover today during the course of my talk, starting first with what tyrosine kinase inhibitors are and how they work. I'll also review data supporting the efficacy of tyrosine kinase inhibitors in the treatment of neuroendocrine tumors, and end with some words about the side effects of TKIs. I want to start first with an overview of the treatment of well-differentiated neuroendocrine tumors. As a reminder for everyone, well-differentiated neuroendocrine tumors are different from poorly differentiated neuroendocrine carcinomas, which are treated differently and which I won't cover today. The treatments for well-differentiated neuroendocrine tumors can be divided into two broad categories, including local regional therapy and systemic therapy. Local regional therapies that we use for well-differentiated neuroendocrine tumors include surgery, ablation, hepatic artery embolization, and an emerging technology called histotripsy. As the name might suggest, local regional therapies are used to control areas of localized disease. Surgery can be curative if disease has not spread and surgeons are able to completely resect the areas of disease or areas it might have spread to. The goals of local regional therapies are to reduce the burden of disease, improve long-term outcomes, and also can improve symptoms related to disease. In contrast, systemic therapies are used to treat more extensive areas of cancer after spread has occurred. The examples of the systemic therapies that we use for well-differentiated neuroendocrine tumors include somatostatin analogs like octreotide and lanreotide, molecularly targeted therapy, which I'll spend more time talking about today since tyrosine kinase inhibitors are a form of molecular targeted therapy, chemotherapy, and peptide receptor radionuclide therapies. Systemic therapies treat the entire body and are administered by mouth or intravenously. They're given subcutaneously or intramuscularly. They can reduce disease burden by shrinking areas of disease. They also can slow tumor growth, and they can improve symptoms related to the burden of disease or hormones that may be secreted by disease. Molecular targeted therapy for neuroendocrine tumor is a type of cancer treatment that targets proteins that control how cancer cells grow, divide, and spread. Targeted therapies can work by, for example, stopping signals that help form blood vessels. They can also interrupt signals that causes cells to grow uncontrollably and divide. The examples of molecularly targeted therapy that we use to treat neuroendocrine tumors include tyrosine kinase inhibitors, which I'll review today. The mTOR pathway inhibitors include agents like everolimus, which we also use to treat neuroendocrine tumors. So what are tyrosine kinase inhibitors? As mentioned, tyrosine kinase inhibitors are a form of targeted therapy. They work by blocking the action of enzymes called tyrosine kinases that can transfer a phosphate group to tyrosine residues and proteins that are found inside cells. So that really is a lot of information to process. And in the next slide, I'll use a figure that'll help to explain this in a little bit more detail and with a visual that will help. It's important to recognize that this is an important step for triggering signals that can lead to growth of cancer cells and spread. So this is a figure that shows the surface of a cancer cell membrane. In the membrane, there are receptors for growth factors, which are signaling molecules bind to these receptors. And by binding these growth factors to the receptors, that can trigger the activity of downstream signaling that can lead to responses that include cancer growth and spread. Specifically, tyrosine kinase inhibitors work by transferring a phosphorus group to the tyrosine residues that are on the proteins. The way that tyrosine kinase inhibitors work is they stop that process of adding the phosphorus groups to the tyrosine residues. It then stops the activation of the receptors and stops the processes, including survival of cells, stops growth and spread. One thing that's important to note is that there are multiple types of tyrosine kinase receptors, and they each trigger different downstream signaling pathways that lead to cell growth and spread. In this figure, it's a representation of the different types of tyrosine kinase inhibitors that can exist, including, for instance, VEGFR, PDGFR, FGFR. And again, each of these receptors triggers different downstream signals that can lead to cancer growth and spread. The other important thing to note is that there are many different tyrosine kinase inhibitors that have been developed, and each of these tyrosine kinase inhibitors varies from one another by the different receptors that they target. For instance, sunitinib targets VEGFR, PDGFR, KIT, and RET. And this is a different panel of receptors and is inhibited by other tyrosine kinase inhibitors that include, for instance, Cabozantinib, which also can inhibit VEGFR, but inhibits also RET and a receptor called MET. The other important point to note is that neuroendocrine tumors are very rich in blood vessels. The process of forming new blood vessels, which is called angiogenesis, is driven by signaling through a growth factor called vascular endothelial growth factor and its tyrosine kinase receptor, VEGFR. Tyrosine kinase inhibitors that inhibit VEGFR can block angiogenesis as a way of controlling growth and spread of neuroendocrine tumors. Many of the tyrosine kinase inhibitors that have been studied in neuroendocrine tumors inhibit this VEGF receptor. I'll start with a summary of tyrosine kinase inhibitors and their role in the treatment of neuroendocrine tumors. At this point, the only tyrosine kinase inhibitor that's approved by the FDA for treatment of neuroendocrine tumors in the US is sunitinib for pancreatic neuroendocrine tumors. Other tyrosine kinase inhibitors, including axitinib, pazopanib, surufatinib, lenvatinib, have demonstrated activity in neuroendocrine tumors but are not FDA approved for the treatment of NET. Cabozantinib is a tyrosine kinase inhibitor that improves progression-free survival in pancreatic NET as well as extrapancreatic NET, and this is based on the results of the phase 3 CABINET trial that we recently presented. And based on these results, cabozantinib may become a new treatment option for patients. I'll next go into the details of the results of the trials that have been done that have evaluated tyrosine kinase inhibitors in neuroendocrine tumors. Starting first with sunitinib in pancreatic neuroendocrine tumors. Sunitinib was studied in a phase 3 trial that enrolled patients with pancreatic neuroendocrine tumors. Patients in this trial were enrolled and received either sunitinib starting at a dose of 37.5 milligrams daily or placebo. For patients who were randomized initially to receive placebo, there was an option to receive sunitinib at the time of cancer progression. Patients who were treated on the trial were followed for cancer growth or spread. This is the primary endpoint that we call progression-free survival, which is a measure of the time that it takes for the cancer to grow by a certain amount or spread. As you can see from the results at the bottom of the screen, patients who received sunitinib had a longer progression-free survival duration compared to patients who received placebo. And this result ultimately led to the approval of sunitinib for the treatment of pancreatic neuroendocrine tumors in 2011. What you can also see from the chart that is at the bottom of the screen is that the response rate, which is a measure of how much shrinkage may occur in patients who receive treatment, occurred in less than 10% of patients who received sunitinib, compared with no patients who had received placebo. And what this tells us is that sunitinib and tyrosine kinase inhibitors can work by slowing the growth of disease, but not necessarily achieving dramatic shrinkage in the burden of disease. There, over the years, have been other randomized trials that have evaluated tyrosine kinase inhibitors in neuroendocrine tumors, including 2 phase 3 trials that were conducted in China that evaluated the tyrosine kinase inhibitor surufatinib, which targets the receptors that are listed in this table. These trials evaluated, in one case, the role of surufatinib for the treatment of extrapancreatic neuroendocrine tumors, and the second trial evaluated surufatinib in patients with pancreatic neuroendocrine tumors. I'll stop here by just explaining that we use the terminology extrapancreatic neuroendocrine tumors to refer to neuroendocrine tumors that arise in organs not including the pancreas. This commonly can include organs in the GI tract like the small intestine, but also stomach and colon. It also can include patients who have lung neuroendocrine tumors or neuroendocrine tumors that arise in unknown primary sites. As you can see from the results in this table, surufatinib improved progression-free survival in patients with extrapancreatic neuroendocrine tumors and pancreatic neuroendocrine tumors. The response rate was 10% in patients who had extrapancreatic neuroendocrine tumors and 19% in patients with pancreatic neuroendocrine tumors. These response rates are slightly higher than what we're seeing with sunitinib, but again showing that tyrosine kinase inhibitors can slow disease progression without necessarily achieving a radiology response. Because this trial was conducted in China, the approval for surufatinib is limited to China. It was not approved by the FDA or EMA. Other tyrosine kinase inhibitors, including pazopanib and axitinib, have also been evaluated in randomized clinical trials in patients with extrapancreatic neuroendocrine tumors. In the case of pazopanib, there was an improvement in progression-free survival compared with placebo. However, further development was not pursued. In the case of axitinib, there was an improvement in progression-free survival compared with placebo, but this was not statistically significant, and further drug development has not been pursued. Lenvatinib is another tyrosine kinase inhibitor that has been evaluated in a phase 2 trial conducted by colleagues in Spain that included patients with pancreatic neuroendocrine tumors and GI neuroendocrine tumors. What was notable about the results of this trial was that there was a high radiographic response rate. 44% of patients who received treatment with lenvatinib who had pancreatic neuroendocrine tumors had an objective reduction in their disease on their radiology scans. And this was true also for 16% of patients with GI neuroendocrine tumors. There was a relatively long duration of response and progression-free survival seen in this trial. However, despite these encouraging results, further drug development has not been pursued in neuroendocrine tumors for lenvatinib. This leads me to cabozantinib, which is also a tyrosine kinase inhibitor. It inhibits VEGF receptors, MET, AXL, and RET. It is approved for treatment of advanced renal cell carcinomas, thyroid carcinoma, and hepatocellular carcinoma. In preclinical models of neuroendocrine tumors, cabozantinib has been shown to inhibit the viability of cells and can also decrease spread and invasion. Several years ago, we conducted a phase 2 trial of cabozantinib in patients with neuroendocrine tumors at Dana-Farber Cancer Institute and Mass General Hospital. The results of this trial were encouraging in terms of response rates and progression-free survival times. So based on these results, the CABINET trial, which is a phase 3 trial, was designed to evaluate the efficacy of cabozantinib in patients with extrapancreatic neuroendocrine tumors and pancreatic neuroendocrine tumors. The trial was stopped in August 2023 based on the results of interim analyses that demonstrated improvements in progression-free survival in patients who received cabozantinib. So I'll explain a bit more about the trial in the next few slides. This is a trial that provides an overview of the study design for the CABINET trial. As mentioned before, there were 2 cohorts of patients. The first group of patients included those who had extrapancreatic neuroendocrine tumors. The second had pancreatic neuroendocrine tumors. Both groups were randomized in a 2-to-1 fashion to receive cabozantinib starting at a dose of 60 milligrams daily or placebo. Patients continued cabozantinib or placebo daily until there was progression of disease or patients stopped for other reasons. The primary endpoint or the primary goal of the study was to look at progression-free survival duration. We included patients who had well to moderately differentiated neuroendocrine tumors. They could be grades 1 through 3 tumors. Disease progression prior to enrolling on the trial was required. Also required was that patients have progression or experience some intolerance of at least one prior FDA-approved systemic therapy, not including somatostatin analogs for their disease. So this could include everolimus, sunitinib, or lutetium-177 dotatate for patients with pancreatic neuroendocrine tumors. It could include everolimus for lung neuroendocrine tumors. And for patients with GI neuroendocrine tumor, prior therapies could include everolimus or lutetium-177 dotatate. Patients were able to continue somatostatin analog therapy as long as their dose of somatostatin analog therapy had been stable for at least 2 months. This table gives an overview of the characteristics of patients who enrolled in the extrapancreas neuroendocrine tumor cohort. There were almost 200 patients who enrolled in this cohort, and I won't go through the details that are described in this slide, except to note that most patients had grade 1 to 2 neuroendocrine tumors. There were a small number of patients who had grade 3 neuroendocrine tumors. Over half of patients had GI primary tumors, but about 20% of patients had neuroendocrine tumors that originated in the lung, and others had unknown primary tumors. As you can see from the bottom column on the right hand of the screen, many patients had received multiple lines of prior therapy. Most patients had received everolimus, many had received lutetium-177 dotatate, and other patients had received chemotherapy. The next slide is a summary of the primary results for the extrapancreatic neuroendocrine tumor patients, which was progression-free survival. As you can see from the slide, the patients who received cabozantinib, as indicated in this red line in the figure, had an improvement in progression-free survival compared to patients who received placebo. This was an almost doubling of the progression-free survival time in patients who had received cabozantinib versus placebo. I'll turn next to the results in the pancreas neuroendocrine tumor cohort. This cohort enrolled over 90 patients. Again, I won't go into all of the details that are in this table, but again, we enrolled mostly grade 1 and grade 2 patients with pancreatic neuroendocrine tumors. Most patients had also received multiple lines of prior therapy. Many patients had received everolimus. Many had received lutetium-177 dotatate. Over half had received chemotherapy with temozolomide with and without capecitabine. About a quarter of patients had received sunitinib. The results of the pancreas neuroendocrine tumor cohort are presented on this slide. As seen in the extrapancreas neuroendocrine tumor cohort, there also was improvement in progression-free survival for patients receiving cabozantinib compared with patients receiving placebo. And this translated into an almost tripling of the progression-free survival duration for patients receiving cabozantinib compared to placebo. Based on these results, we concluded that cabozantinib significantly improves progression-free survival in patients with previously treated extrapancreatic and pancreatic neuroendocrine tumors. The interim analyses that I just reviewed in both of the cohorts showed statistically significant and also clinically meaningful improvements in progression-free survival in patients who were treated with cabozantinib. Based on these results, the Independent Data Safety Monitoring Board voted to stop accrual to the trial. Patients were unblinded, which means that investigators were able to find out which treatment patients were receiving, and the patients who were receiving placebo were able to then cross over to receive cabozantinib. The adverse events that we observed in the trial are consistent with a known safety profile of cabozantinib. In a few minutes, I'll review the side effects that we can see with cabozantinib and other TKIs. And again, based on the results of the CABINET trial, we believe that cabozantinib may be a new treatment option for patients with previously treated progressive neuroendocrine tumors. The next slide shows the current systemic therapy options that are available for well-differentiated neuroendocrine tumors. And I've broken this down by primary tumor sites, starting first with GI neuroendocrine tumors, where we often start with the somatostatin analog, and following that, patients might receive PRRT or everolimus. For patients with pancreas neuroendocrine tumors, we also might start with a somatostatin analog, and then patients after progression might receive PRRT, or everolimus, or sunitinib, or potentially capecitabine and temozolomide. For patients with lung neuroendocrine tumors, somatostatin analogs sometimes are used, especially if disease is somatostatin receptor positive, as seen on a dotatate PET-CT scan. However, somatostatin analogs are not approved by the FDA for treatment of lung neuroendocrine tumors. Other options can include everolimus or potentially chemotherapy for lung neuroendocrine tumors. Based on the results of the CABINET trial, it's possible that cabozantinib may become a new treatment option for patients with GI, pancreas neuroendocrine tumors, lung neuroendocrine tumors, or unknown primary neuroendocrine tumors, particularly if there has been growth or spread of disease after prior therapy. We'll find out hopefully soon whether Cabozantinib will become an FDA-approved treatment option for patients with neuroendocrine tumors. However, I'm optimistic and I'm hopeful that we can add to the available treatment options for patients. Many patients ask, even if a drug is not FDA approved, whether it's possible to receive treatment. And the answer is often yes. We sometimes, if a drug is approved, for instance, for another indication, we can prescribe these medications in what is called an off-label fashion, meaning that it's outside the approved indications for disease. One thing to note about this off-label prescribing process is that it may or may not be covered by insurance. Having FDA approval or having endorsement by guidelines can be very helpful for the drug approval process and minimizing the number of steps that are required. Some of these are very frustrating steps to try to get access to drugs. I'll turn next to side effects of tyrosine kinase inhibitors. Some of the more common side effects of TKIs include fatigue, mouth sores or changes in taste. Thyroid dysfunction can develop on treatment and should be monitored. Hypertension, nausea, vomiting, and diarrhea can occur on treatment, and patients might experience hand, foot, skin reaction. I'm going to talk about a few of these common side effects in more detail, starting first with hand, foot, skin reaction. And this occurs when patients might develop swelling, redness, or tenderness on the palms or the soles of their feet. This often localizes to area of pressure and areas where there's friction that might be caused by shoes or repeated motions. There can be development of blisters or callus formation as part of this reaction. Some of the important tips for managing hand-foot skin reaction are to keep the skin as well moisturized as possible, to wear comfortable and not tight shoes, to try to avoid repetitive motion that can cause more friction. And then urea-based creams, which are a type of moisturizing lotion, can be very important for helping the skin to heal and to keep it moist. Hypertension is a common side effect that can occur with tyrosine kinase inhibitors based on the way that they can affect blood vessels and angiogenesis. Sometimes hypertension that develops on tyrosine kinase inhibitors can be severe. It may be possible or necessary to start doses of antihypertensive medication or adjust the doses that you may be on to help treat blood pressure elevation. One thing that can be helpful is to keep regular records of blood pressure while you're on treatment to share with your medical care team to help with adjustment in any medications that might be necessary to treat hypertension. It's also really important to call your medical care team when you develop any new or worsening symptoms that might be related to blood pressure that can include headache, vision changes, or chest pain. Diarrhea can develop on tyrosine kinase inhibitors, and one thing that can be helpful is to be proactive with its management. Dietary changes can be helpful, including eating small and light meals and avoiding spicy, greasy, fatty foods that can trigger diarrhea and other bowel movement changes. Keeping a diary of food that you eat and keeping track of how often diarrhea is happening can also be helpful. As with diarrhea that develops with any other illness or side effect of treatment, it's important to stay well hydrated. Some medications that can be used to control diarrhea include loperamide, which is Imodium, or diphenoxylate atropine, which is Lamodal. Mouth sores, or what we call mucositis, also can develop on tyrosine kinase inhibitors, and it's important to keep your mouth clean with good oral hygiene. It can also be helpful to use rinses that include baking soda or salt with water, and to avoid irritating mouthwashes that have alcohol. There are medications and mouth solutions that also can be prescribed that can help with numbing the pain that can be related to mucositis. Some of the less common but potentially serious side effects of tyrosine kinase inhibitors that can develop include blood clotting events. So it's important to make sure you watch out for swelling or pain that might develop that could be an indication of development of a blood clot that might happen in your, for instance, legs. Bleeding because of the effect of tyrosine kinase inhibitors on blood vessels can also happen. And tyrosine kinase inhibitors also can impair wound healing and at times lead to intestinal perforations. Some of the tips to managing side effects of tyrosine kinase inhibitors include close monitoring for any side effects that might develop, It's important to stay in regular communication and to have regular visits with your care team to assess for side effects, because we also recognize that early intervention, which could include stopping therapy for a short period or reducing doses of treatment, those early interventions can help minimize the side effects of treatment. Proactive management with some side effects that include hand-foot skin reaction and diarrhea can be very helpful. And as mentioned before, dose delays and dose reduction may be necessary to manage side effects. I know that there's always concern about reducing doses of treatment or stopping treatment, but this really I wouldn't think of as anything to be too alarmed about or to worry about, because these important dose delays and reductions can be helpful for being able to stay on treatment, particularly if it's helping disease control. So in conclusion, tyrosine kinase inhibitors play an important role in the management of neuroendocrine tumors. Several tyrosine kinase inhibitors have been evaluated in neuroendocrine tumors. Currently, sunitinib is the only FDA-approved treatment for pancreas neuroendocrine tumors. Although encouraging results have been seen with tyrosine kinase inhibitors, including axitinib, lenvatinib, pazopanib, and surufatinib, they are not approved for treatment of neuroendocrine tumors. Cabozantinib, however, may be a new treatment option for patients with pancreatic neuroendocrine tumors, as well as extrapancreatic neuroendocrine tumors. Finally, side effects of tyrosine kinase inhibitors, as mentioned, can be managed with close monitoring, proactive management, and early observation. So I want to end with a thank you for your attention, and I'm looking forward to discussion.
Thank you, Dr. Chan, for your very informative presentation. I really appreciated the really helpful overview of what this class of medications are, how they work, the different medications and classes, and all the tips and tricks for managing side effects as well. So thank you for giving us so many gems here. And thank you for taking the time to answer questions. Yeah. Yes.
Thanks. It's great to be with you here.
Thank you for taking the time to answer the questions from the audience. And for our audience, this question and answer session is for educational purposes only. It does not substitute for medical advice. And we encourage you to talk to your own medical team with your own specific questions or concerns about your individual care or treatment. So there are over 35 questions. We will try to get to as many general questions as possible, but we may not cover all the questions. And we will be covering the questions in an order that makes sense to ask and not necessarily in the order they were submitted. Please note that we will address general questions only, and Dr. Chan will be answering the questions generally as well. She cannot provide specific feedback on your own specific situation. So with that, Dr. Chan, let's start with this general question about TKIs. And I think this is a really good question. Do TKIs work on neuroendocrine carcinoma? I know we didn't cover this in the talk, and this is a helpful thing to cover.
Yeah, I think this is a really important question. I'm glad that it was asked. And I think it's important, again, to recognize the difference between well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas. They are very different in their biology. They're also very different in terms of prognosis as well as treatment. Many times we will think of using chemotherapy to treat poorly differentiated neuroendocrine carcinomas, sometimes immunotherapy, and there are a lot of exciting drugs that are in development for neuroendocrine carcinomas. We don't know the activity necessarily of tyrosine kinase inhibitors for poorly differentiated neuroendocrine carcinomas in the level of detail that I showed for well-differentiated neuroendocrine tumors. So I think to answer this question of do TKIs work in neuroendocrine carcinoma, I would have to say at this point we don't have any evidence that this would be an effective treatment strategy. So I would probably recommend pursuing some of the other types of therapy that I mentioned, like chemotherapy, potentially immunotherapy, or other clinical trials.
Thank you for addressing this. And we will be having a dedicated webinar on high grade on neuroendocrine carcinomas in May with Dr. Man Chauhan, so we can dedicate some specific time just to this special population as well. So you talked about the potential for dose reductions at the end of your presentation, and this question came up: are dose reductions common with TKI drugs? And if so, is there merit to starting at a lower dose, or do doctors always want to start with the highest dose?
This is also a terrific question, a very practical question. I think anytime somebody is on a tyrosine kinase inhibitor, we always ask that exact question. It is quite common to need some dose modification of tyrosine kinase inhibitors. And I think it really does need to be individualized. Some patients, for instance, may be more sensitive to certain side effects, or some people may be on treatment for longer periods of time and over time need some adjustment in the dose. I would say that for the most part, I tend to try to start with, for instance, with cabozantinib, if I'm prescribing it, it might be to start with the dose that was studied in the clinical trial, and then I might work my way down as needed, because it's very difficult to predict what side effects patients may have. We also don't necessarily know that starting at a lower dose will lead to the same efficacy that we saw with the clinical trial. I think that being said, there are some situations where we might want to start with a lower dose and potentially work our way up. And it might really, again, need to be individualized depending on doses of treatment that we think patients can tolerate.
Yeah, individualized care. Thank you.
Exactly.
And here's another practical question. How long can you be on a tyrosine kinase inhibitor like cabozantinib or lenvatinib?
Again, this is something that will also be individualized. It really will depend on issues like how well it's working. It also will depend on side effects. For some patients, I've taken care of people who've been able to stay on it because it's working even for years. So I think it really will depend. Really, there's no necessary stopping point, which is a little bit different, for instance, and with chemotherapy, where we might set out to complete a set number of cycles of treatment or might have to stop after a certain amount of chemotherapy. I think with TKIs, if they work and if there's a dose that's tolerated, patients continue for quite a while as long as it's working, as long as it's well tolerated.
Thank you. And I know you covered the cabozantinib trial and the findings from it. What is the current status of the cabozantinib approval or off-label use for neuroendocrine cancer? And how long might it be before we can possibly see this as a treatment option for NETs?
Right. So, as mentioned, it is not FDA approved. We are finalizing some of the analyses for the trial. I think there is a goal to have the data submitted and evaluated by the FDA, but I don't have an exact timeline on that. We're hopeful that it may be sometime soon, but I don't have any specific details.
Okay, so we'll stay tuned for future news. You mentioned lenvatinib and the studies that have been done. Will we see clinical trials for lenvatinib in the future, or I guess more clinical trials? And how would NET patients get access to this drug without its FDA approval for NETs?
Right. Right now, as far as I'm aware, there aren't any further trials that are planned with lenvatinib. It may be, for instance, that if lenvatinib is thought of as a good option for patients based on data that exists and after discussion with medical providers, it may be that it could be prescribed and used in an off-label fashion. But I'm not aware that there will be larger scale trials to evaluate this in neuroendocrine tumors specifically.
Another special population is definitely our lung or thoracic neuroendocrine tumors. So can TKIs be used for lung neuroendocrine tumors that have spread?
Yes, I would say the answer is yes. And I think that this is one area where we have not had an approval for a TKI. And the same is true for GI neuroendocrine tumors. A TKI is not approved, but we have recognized that the VEGF pathway, that angiogenesis pathway, is important for the growth and spread of neuroendocrine tumors. Specifically, in many of the extrapancreatic neuroendocrine tumor clinical trials, patients with lung neuroendocrine tumors have been included. 20% of the patients in the CABINET trial had lung neuroendocrine tumors. And I think we're seeing activity of the agent in this population. So again, we'll be able to share more details in the future, and I'm hopeful that it might be a consideration.
Hopeful. We need more treatment options for lungs, for sure. Thank you for doing that. So this is another good question. Are there any specific mutations that increase the efficacy of a TKI?
Also a really great question in terms of like predicting whether a treatment may work or not. We don't have any predictive biomarkers to be able to identify which patients with neuroendocrine tumors may have benefit and those who may not. I think what we did observe in the CABINET trial, and I think you can see this from some of the other studies that have been done in neuroendocrine tumors, is that patients with pancreatic neuroendocrine tumors seem to be more responsive to this class of medications. But in terms of which patients within each of these subgroups based on primary tumor site will respond and not, we don't yet have a way to identify that. So I'd say that, depending on each patient, what their goals of treatment are, what treatments they've received in the past, I think TKIs certainly could be used.
Thank you. So there's other medications out there, of course, that are commonly used. How does everolimus compare to cabozantinib?
So everolimus has a different mechanism of action than the tyrosine kinase inhibitors. I think that's probably the most important difference for any medication is how is it working. So the mTOR inhibitors, like everolimus, they block a different pathway that ultimately signals growth of tumors. In terms of efficacy, they've not been compared head to head. So I don't think we're able to tell people that everolimus will work better than cabozantinib or vice versa. I think these may be options that should be considered. Both of these options should be considered. Sometimes what we will consider that'll help decision making is, again, looking at patients and even comorbidities that might help influence whether we think a certain agent will be tolerated more than the other. Everolimus, for instance, can be associated with hyperglycemia and might be also associated with what we call pneumonitis, an inflammation in the lungs. So patients who have diabetes or who might have underlying lung conditions, we might be a little bit more reluctant to use everolimus. Cabozantinib and the other tyrosine kinase inhibitors, as I mentioned to you, have other side effects. And for instance, if someone has cardiovascular disease or who might have had a recent major surgery or be prone to bowel obstructions, we might be more inclined not to use a tyrosine kinase inhibitor. So efficacy, to answer the question, I don't think we can tell, but they certainly differ in their mechanism as well as side effects.
So speaking of side effects, I know you covered many, and there are several good questions about side effects as well. So because TKIs affect VEGF receptors, does this mechanism affect blood flow and blood pressure as well?
Yes, because of the way these tyrosine kinase inhibitors work, one of the common side effects that we can observe is hypertension and other cardiovascular side effects like blood clotting, very rare risks, but certainly real risks of heart attack or in some cases stroke can be seen with these VEGF pathway inhibitors, including tyrosine kinase inhibitors. So that's why we really do need to watch blood pressure carefully, use antihypertensive medications as needed. Sometimes dose adjustments also need to be made.
You know, I've heard people say, well, my blood pressure is normally low. Can this also cause high blood pressure, even though my blood pressure is normally low?
It can. And I think, again, it's something that needs to be monitored. So that's where it's really important as these agents are being considered to make sure that you're seeing your doctor regularly. Even having a blood pressure cuff at home can be helpful so that you can have some monitoring rather than just the once a month or whenever you're seeing your physician visits, even just a kind of more daily log of what's happening in your usual life.
Yeah, thank you. And this is just a practical question too. Who would change your blood pressure medications? Would it be the oncologist then or a different doctor?
You know, I think it's really important. That's a great question. I think it's important for patients to still be in touch with their primary care doctors. I think in terms of medication adjustment, it could be either the oncologist or a primary care physician. It really may depend on who you're seeing most. It's also important for primary care doctors and oncologists to be aware of what's happening with a patient's cancer and the medications that they're on and the side effects to watch out for.
Okay, thank you. So there are, again, other side effect questions. You mentioned the heart, and we're talking about blood flow. Are there special considerations for patients with carcinoid heart disease, and is there a risk of heart failure?
For anybody who has any underlying cardiovascular disease, whether it's carcinoid heart disease or coronary artery disease, it's really, I think, important to, as we evaluate candidacy for treatments, including tyrosine kinase inhibitors, I think it's important to kind of take that into account. It's not necessarily a contraindication to using a tyrosine kinase inhibitor if carcinoid heart disease is well controlled, heart function is good. There are small risks of cardiovascular changes like heart failure that can occur with tyrosine kinase inhibitors. So we just have to be aware of these risks and monitor.
Okay, monitoring is important. And are TKIs similar to CAPTEM, where prolonged use can cause bone marrow issues?
Tyrosine kinase inhibitors work differently than CAPTEM, which falls into class of cytotoxic chemotherapy. So the side effects that we see with tyrosine kinase inhibitors are different than the side effects that we see with chemotherapy. Tyrosine kinase inhibitors sometimes can affect blood counts. It can, for instance, reduce platelet counts. Sometimes it can reduce white blood cell count. It does it through a different mechanism than I think what we see with chemotherapy. So I would say that prolonged use with chemotherapy, we sometimes will see a cumulative effect on blood counts because of the impact on the bone marrow. I think it's different with tyrosine kinase inhibitors, where if we see some of these effects, we can adjust dose and the impact is not quite as prolonged as what we see with chemotherapy, where recovery might take longer.
Okay. And this is helpful to understand too. Does being on a TKI complicate undergoing other medical procedures such as a colonoscopy or dental work?
Yes, also another important point, the tyrosine kinase inhibitors and other angiogenesis inhibitors in general can impact wound healing. So we do have to take into account whether someone has had a surgery or is planning to have a surgery when we start thinking about using these medications or taking a break, a short pause in the treatment to allow, for instance, surgeries and healing to occur. Dental work, if it's just a cleaning, doesn't necessarily require stopping treatment. However, if there's more invasive dental work, like a tooth extraction that's planned, you really do have to be careful with those types of procedures because the jaw needs to heal after these dental procedures, and you may want to take a pause from treatment. Sometimes we will stop treatment for a few weeks before a planned surgery or dental extraction and then resume the treatment after the healing has occurred. In terms of a colonoscopy, I think you may want to also potentially consider a short pause, especially if, during a colonoscopy, they find something and they may want to remove, for instance, a polyp. You would want that area to heal. It may not necessarily have to be quite as long of a break as you would for surgery or some other planned more invasive procedure. But certainly anytime you're having a procedure that would require wound healing, and if you're on a medication like a tyrosine kinase inhibitor or other angiogenesis agent, it's important to discuss with your care team whether you have to stop treatment. Some of the other angiogenesis agents besides tyrosine kinase inhibitors that we use in oncology, maybe, for instance, the antibodies, bevacizumab also is an antibody that can impact angiogenesis. And there are also other tyrosine kinase inhibitors that can be used that I didn't mention during the course of my talk for other types of diseases where we have to be careful as well.
Okay, thank you. Thanks for that clarity. I hear that TKIs impact the thyroid. What does this mean and what needs to be monitored?
Good question. So the tyrosine kinase inhibitors can sometimes cause lower thyroid function, hypothyroidism. So we will periodically monitor thyroid function with a TSH check while patients are on therapy. And, for any symptoms that might be suggestive of hypothyroidism, like more profound fatigue or weight gain or cold intolerance, sometimes we will check to make sure that thyroid function is intact in situations like that.
What about people who have already had thyroid surgery or are taking medications for their thyroid?
So, if you're on thyroid hormone replacement, I think usually patients will have some monitoring plan in place with whoever is prescribing that medication. I would continue to follow that. I think because, for instance, if thyroid surgery has already happened, it may not be as critical of an issue because the thyroid gland has already had some surgery, but the amount of replacement you may need to be on may need to be adjusted. If the whole thyroid is removed, it may not be as much of an issue, but if there is still some residual thyroid, the medications can impact function. So you might have to have some adjustment in medications.
Thank you. Thanks for that clarity. So TKIs seem to pack a punch to the liver and liver enzymes. Is this something you see plateau or decrease over time?
So the TKIs can impact the liver enzymes, and oftentimes we might find this with routine blood work. In many cases, it's not particularly severe, but we can see some mild elevations in liver function tests. Sometimes, depending on the level, we might adjust the dose and then that might improve. It may not necessarily be that the dose has to be adjusted, and then as long as it's in an acceptable range, we can continue treatment at that same dose. It may not necessarily improve without adjusting the dose, but as long as it's in an acceptable range, we'll continue to follow those levels and monitor.
Okay, yeah, thank you. So there's some questions about the various TKIs and basically how do you choose one over the other?
Good question. They're all different. They are different in terms of the receptors that they inhibit. To some degree, that may impact side effects. I don't think we have a lot of information yet about the differences in efficacy of one tyrosine kinase inhibitor versus the other, again, because they've not been compared head to head. So I think choice may depend on In some cases, it's related to logistics and what's approved and what's available. And I think we also look to the data also to help guide us with, choice. So that's again where the strength of the data and approvals become very important to consider.
Yeah, and thanks for touching on that in your talk. Similarly, someone asked, actually, there's two questions around this. Would you choose cabozantinib over sunitinib, and do you see cabozantinib phasing sunitinib out completely?
That's a really good question. I think, whether it is phased out completely is hard for me to say. What I can say is that in the case of cabozantinib, and if we were to go back again to the clinical trial data, we saw that there was activity of cabozantinib in patients who had received prior sunitinib and also in patients who had not. So I think it's certainly something you could, for instance, turn to cabozantinib before sunitinib. Whether it'll phase it out completely, I think it's hard to know. I think sunitinib is still an option for some patients, but you may not necessarily have to have sunitinib before you choose something like cabozantinib.
Thanks. And back to cabozantinib, now that the CABINET trial has ended, how do NET patients get the medication and pay for it? And then is FDA approval on the horizon, which I know we've already covered?
Yeah, I think we touched on the FDA approval. I think it is hopefully something that may happen. I think we'll ultimately have to, see what happens with the review process. How do patients get it now? I think, again, turns back to that off-label prescribing practice, depending on what options patients have. If it is after a discussion with medical providers, certainly something that seems to be a next option. I think we will often prescribe the medication and then have to see what happens with the drug approval process. Some insurance companies may cover it off-label. It may or may not be denied, though, and I think that's where it's a little bit harder to predict in a situation like this.
So the importance of the clinical trials and the FDA process. So this person said she was on cabozantinib through the CABINET trial, so thank you for your participation in that. Even though I had progression, did it keep all the other liver tumors from growing and no new lesions?
That's a great question. I also want to extend my thanks for all of the patients who participated in this study. I think it is really a lot of information that we're learning from the trial, and we definitely could not do any of these studies without the participation of patients. So I'm very grateful for that. I think with respect to that question of did it keep some of the liver tumors at bay or maybe slow down the process of developing new lesions? I think this question really speaks to the heterogeneity of disease, where we, with certain treatments, can see areas of disease not growing and some areas of disease growing. I think when we start to think about the overall treatment plan, I think we have to consider everything. And if the overall picture looks like most of the disease is growing, we ultimately will stop those therapies and switch to something different. But whether or not cabozantinib or that whatever other treatment it might have been that kept some disease at bay was helping, I think that's always hard to answer. And I think the answer is potentially some disease might have been controlled. But if other areas or other important areas or most of the disease is growing, I think we do have to switch treatment strategies.
Yeah, thank you. This is a very complex question, and thank you for addressing heterogeneity, which is a hard concept sometimes to wrap our minds around. I was glad to see that there are grade 3 NETs included in your trial, and this person is asking for the data on the PFS, or the progression-free survival, in G3P NETs in the CABINET trial.
Yeah, that's a great question. I think we are hopeful that we're going to be able to have all of the final data ready to present. That'll break it down into certain subgroups where we'll be able to share information about, for instance, lung and GI and certain grades. But yeah, no, this is an important question. I think we're looking forward to sharing the information.
Thank you. So going back to one TKI versus another, if one stops working, could you see another one work? So if cabozantinib stops working for a person, could a patient see another TKI, such as lenvatinib, work for them?
I think for this particular question and example, I don't think we have data to know the answer to that. I think it's possible. My general sense is that the receptors are different. So there are some differences in what we have seen in practice is that patients, for instance, who had been on sunitinib for pancreas neuroendocrine tumors, then moving on to cabozantinib, there is still activity in that situation. So I have no evidence specifically about lenvatinib after cabozantinib, but I do think that there are differences in TKIs where we might be able to consider another TKI after progression on another. And that's a strategy that, for instance, we tested in the CABINET trial, but something that is used in other diseases. So it's a great question, and I think another avenue for research.
Yeah, thank you for addressing that. Actually, it's like you read someone's mind, because someone asked if you took sunitinib for PNET and then the patient responded, but then progressed, could you also use cabozantinib? So, yeah. There's another question. These are questions now about sequencing. How soon after TKIs could you do PRRT?
I think pretty soon. I mean, I guess if this is a question about somebody who's been on a treatment with a TKI and there's a reason to stop it, whether it is because there is growth of the cancer or whether it's stopped for some other reason, I think you could potentially move on relatively quickly to PRT. There isn't necessarily a need to wait a very long time. I always wait a bit of time to make sure that any side effects of treatment have worn off before you move into something new. But, for many people, that may not take an extended period of time.
And I know that you touched on this bone marrow issue, but are TKIs a safer choice than PRRT for a patient at risk for blood cancer?
Yeah, that's an interesting question. I think for patients who may have some underlying bone marrow disorder, for instance, myelodysplasia that could progress into leukemia, I am a bit wary of using PRT in those situations because you could potentially accelerate that process. So I might shy away from using PRT, and for instance, then I might choose a tyrosine kinase inhibitor or something that might have less of an impact on bone marrow function. I think, in terms of the question of whether or not even just risk of blood cancer, but let's say somebody's blood counts are low for whatever reason, where PRT may be more impactful on bone marrow function, we might also choose something like a TKI in a situation like that, where the dose of that treatment may not have as much impact on bone marrow function and may not be quite as long lasting for recovery.
Okay. That's helpful. It's helpful to hear your thoughts on one versus another. And this person asked if you would be able to take a TKI after being on Afinitor for a while.
Yes, the answer to that question is yes. And it also gets into kind of that sequencing question. Like if you had been on everolimus, Afinitor, and for some reason needed to stop, then you could switch to a TKI. And that essentially is the group of patients that we had studied in the CABINET trial, patients who may have had another prior treatment, including Afinitor.
Yes, and from what I remember from the CABINET trial data, some of them had multiple lines of therapy. I think up to 7 was the maximum, from what I remember.
Yeah, there were some patients, exactly. There were some patients in the trial who had a number of different prior therapies, multiple. And I think again, I would say it's helpful to have as many options as possible, because I think it's hard to predict how well one will work until you have access and are able to try it. So I think what we didn't have in that particular trial, we didn't have a limit to the number of prior therapies that patients could have had. The median number was around 2 in both of the groups, but certainly if you've had more than that, there was no reason that patients could not enroll on the trial.
Thank you. We definitely need those type of studies that are taking people with multiple prior therapies. This is another good question. Are TKIs considered an alkylating agent, and could you define that? Or do they cause any changes to the tumor that can lead to mutations of the disease down the line?
So tyrosine kinase inhibitors are different than alkylating agents. So the alkylating agents are in a category of chemotherapy. So the alkylating agents that we tend to use in neuroendocrine cancers include temozolomide. We use streptozotocin, not quite as much now as in the past, but streptozotocin is also an approved agent for treatment of pancreatic neuroendocrine tumors. The way that the alkylating agents work is that they transfer what we call alkyl groups to the DNA, and having these alkyl groups on the DNA prevents replication of DNA. So that's generally how chemotherapy works, is that it somehow modifies or impacts the DNA to prevent replication and then kind of cell proliferation. In contrast, as I explained during the talk, the way that the TKIs work is that they will inhibit those tyrosine kinase receptors that are on the surface of the cancer cell. And by blocking those receptors that are in many cases, dysregulated and drive growth of the cancer, you're able to block that process. So they work very differently. These alkylating agents, as kind of referred to in this question, can sometimes cause mutations to develop in the cancer. Sometimes cancers, for instance, can develop a hypermutated state. We don't see that as much with the tyrosine kinase inhibitors. We don't see as much of a mutational change as we do with alkylating agents and with chemotherapy.
Thank you. Thanks for clarifying that. So do TKIs play a role in the early treatment of metastatic disease, or do you use it later in the course of treatment?
That's a good question. I mean, I think this is often what we will try to discuss and sometimes even debate at our tumor board conferences about when is the right time to do a certain treatment. I think, in terms of whether to use a TKI, we often will use it after another treatment. And, for instance, in the CABINET trial, patients had another prior therapy. So for instance, if somebody had, let's say, a GI neuroendocrine tumor, and often we'll start with a somatostatin analog, we might next turn to PRT, and we might then use a TKI after PRT. But as I just mentioned earlier, we don't always have to save it so late. Sometimes the sequencing question depends on what the options are and kind of picking through what we think might be the best option. For instance, some patients might not necessarily be candidates for PRT, and then we might use it earlier than PRT.
Oh, wow. I was just about to ask this next question, which you just answered. A patient presents with progression. Yes. A patient presents with progression.
What enticed me to use TKI?
Yeah.
Right. So I think, if we were to, for instance, think about lung neuroendocrine tumors, many lung neuroendocrine tumors don't have a lot of somatostatin receptor expression, where we might not even use a somatostatin analog, and PRT is not approved. So I think that's where TKIs may have an important role. For GI neuroendocrine tumors, I would say the strength of the data with PRT is very high, so we might want to prefer PRT before a TKI. And the same, I think, is true for pancreatic neuroendocrine tumors. There has been a randomized trial that was conducted in France looking at PRT versus, in this case, sunitinib, showing improvement in progression-free survival with PRT compared with sunitinib. But again, some patients, for instance, might not necessarily be a candidate for PRT, or maybe the amount of progression is not quite as much as might then trigger the decision to do PRT, but somebody wants to try something different before moving on to PRT. I think the TKIs can control disease in situations like that.
Yeah, thank you for tackling that. This person's already thinking about clinical trials and involvement in that. Could TKIs disqualify a patient from future clinical trials?
I would say not necessarily. And I think this is where every clinical trial is different. So for anyone who is considering a clinical trial, it's really important to ask that question, to ask about the treatment that you're on, or to ask about other treatments that you might be considering and how that might impact eligibility for a clinical trial. So I think it really depends on the trial and what is required in the trial. For instance, I'll kind of turn back again to the CABINET trial. Having been on a TKI did not disqualify patients for being on this clinical trial. We did allow, for instance, patients to have prior sunitinib, and many patients, as I mentioned to you, in the pancreatic neuroendocrine tumor cohort, almost a quarter had prior sunitinib. And even in the extrapancreatic neuroendocrine tumor cohort, we saw a small number of patients who had tyrosine kinase inhibitors. So it may not automatically disqualify you, but you have to look at the specific eligibility criteria for the trial. Some trials will exclude certain types of treatment or a certain number of treatments. So you have to kind of think about that as you think about trials you might be interested in and make decisions about treatment.
Okay, thank you for that helpful tip. There's some questions about combination therapies. So can both everolimus and a TKI be used together to help different mechanisms of action and stop disease growth?
That is also an excellent question, and I think would also be a really interesting clinical trial. One of my colleagues, I think many people may know, Dr. Dasari at MD Anderson. We were just a couple of weeks ago at the NANETS conference, the European Neuroendocrine Tumor Society meeting, and he presented the results of a phase 2 trial that he conducted looking at everolimus and lenvatinib. It was a phase 2 trial, so there wasn't a comparison to other types of therapy. But what was really interesting in that particular trial was the high response rate that he saw in the patients that were treated. In this case, it was patients with extra pancreatic neuroendocrine tumors. And if you look at the response rates, it's perhaps higher than you might expect to see with everolimus by itself or even lenvatinib by itself. So there may be some synergy where there can be a benefit to using treatments in combination. I think we're always wanting to understand risks and benefits when we start to use any treatment. And certainly as we combine treatments, you want to know what is the benefit that you're getting, and is that benefit better than doing something sequentially? And I think that's an important question that only a clinical trial would be able to answer, but there are certainly good rationales for combining these two agents with different mechanism of action that could kind of synergize with one another.
Yes, thank you. There's several questions about TKI and immunotherapy. So one of them is, I've seen cabozantinib be used with immunotherapy for kidney cancers. Is this something we can see for NETs?
These are really terrific questions. A lot of clinical trials are being done to study questions exactly like this. So the way that the TKIs work, and I didn't go into as much detail about this property of TKIs, is that they can also modulate the immune system. They may be able to, for instance, recruit some of these cancer-fighting T cells into the tumor microenvironment. They may be able to suppress some of the immunosuppressive cells. For instance, in some cancers where you're combining a TKI with immunotherapy, it's really to get that synergy and to help the immunotherapy work. There have been some studies that have looked at combining a TKI with immunotherapy in well-differentiated neuroendocrine tumors. We, for instance, at Dana-Farber have looked at the combination of cabozantinib and nivolumab. I don't have results to share with you, but that trial has finished recruitment, and we should hopefully have results to share at some point soon. Dr. Strasberg from Moffitt last year shared the results of looking at pembrolizumab with lenvatinib, and I think what he saw in that particular study is that the response rates were not particularly high, and there weren't any strong signals that this combination would be an effective strategy for neuroendocrine tumors. But I think it's certainly something that has been worth investigating. The role of immunotherapy in these well-differentiated neuroendocrine tumors has been really tough to know, and it may really just speak to the immune environment in well-differentiated neuroendocrine tumors, the low mutational profile of well-differentiated neuroendocrine tumors. But I think there may be other immunotherapy strategies that are worth investigating, including this one. At least from what's been presented so far, we're not entirely sure if this is going to be as effective as it has been for renal cell carcinomas, but definitely an important question to ask. So I'm glad somebody did ask, and I'm glad that these studies will help us to understand what works. And also, I think for clinical trials, they may not always work out the way that we would anticipate or hope to see, but that's also really important information that we're gaining. And I think it helps us to understand pathways that we may not want to continue pursuing. And it also gives us information about other avenues that we should explore. So again, for all of you who have been interested in trials and who have participated in trials, we can't thank you enough for your contributions and what you're sharing with everyone and what we're all learning.
Beautifully said. Thank you so much. And here's another similar type of question. Please discuss the use of sunitinib in combination with Keytruda infusions.
Yeah, that's a very similar question, but with a kind of a different mix-up of the tyrosine kinase inhibitors. So sunitinib with pembrolizumab, again, looking at that combination TKI immunotherapy strategy.
Okay. So this is kind of a general question. I learned that standard chemotherapy doesn't kill all cancer cells. So what are treatment options when the cells multiply and spread?
Right. So not all cancers respond to chemotherapy. And you can even think about well-differentiated neuroendocrine tumors as in that category where some neuroendocrine tumors don't respond to traditional forms of chemotherapy. And I think that's where it is important to think about other processes that may be driving growth and spread, whether it's growth factor signaling pathways where you might be able to target those with molecularly targeted therapies, or for tumors that are reliant on angiogenesis, blocking those pathways. I hope that answers the question. The other thing I was thinking as I read this question online was that if you're on a treatment and you're not killing everything, what could you do? And I think that also gets to kind of this heterogeneity aspect, that it may work in some areas, but not other areas. And then you have to kind of think of the whole picture and whether it's worth sometimes continuing that treatment, recognizing that you're not controlling everything, and maybe you can do something locally to those areas that are not responding, while you continue whatever other treatment that you're on. Or maybe you just have to, if everything is looking like it's not moving in the overall direction you want, you might have to just switch altogether.
Well, thank you. Thank you. Well said. So what are the current treatment or current types of treatments for G3 well-differentiated pancreatic NETs, but in NETs in general? Any experience with Keytruda for tumor mutation burden, especially over 10?
Right. So the well-differentiated G3 NETs is really a subject of a lot of investigation. This is a relatively newly recognized category of more proliferative, well-differentiated neuroendocrine tumors. And it really has been the subject of many clinical trials that have been done or are still enrolling patients. I'd say outside of a clinical trial, we often may think, sometimes depending on how much disease is there, sometimes we might even start with a somatostatin analog therapy if we think that we could do a short trial and then watch very closely. Sometimes, though, if there's a higher burden of disease and we're looking for something that might lead to a more objective shrinkage of disease, we might think about chemotherapy, whether that be capecitabine and temozolomide. Sometimes we will use chemotherapy regimens like FOLFOX to treat well-differentiated G3 pancreatic neuroendocrine tumors. And I think what we learned from the ASCO GI presentation from Dr. Singh was the results of lutetium-177 dotatate and how that also can be active for grade 3 pancreas neuroendocrine tumors, these GI and pancreas neuroendocrine tumors. So I think, again, I would say, and I think this is a good thing, to have all options on the table. Somatostatin analogs, depending on the situation, could be used, but I think we have to recognize that you want to watch carefully, that the somatostatin analogs, while they might have a role, might not work quite as long because of the proliferation rate. We do know from the NETTER-2 trial that the progression-free survival duration of patients treated with lutetium-177 dotatate, so PRT, was higher than with a high dose of somatostatin analog therapy. So I think, again, if you have a more extensive disease burden, a more aggressive disease, you might be wanting to think about something that can lead to a better response, whether that be PRT or whether that even be chemotherapy. So there are some trials that are going to be looking at that question as well.
Yeah, very, very helpful. Thank you, Dr. Chan. So if someone has significant side effects from octreotide or sandostatin, any of the SSAs, would a TKI medication be an option for them?
I think it depends on the situation, but I would say that for patients who have a well-differentiated neuroendocrine tumor and they are looking for a treatment that may be able to control disease, I would also consider this as an option. I think it's also important to think about what the other options might be and then just to kind of weigh the risks and benefits.
Yeah, risks and benefits, that's important. And can both a TKI and an SSA, sandostatin, lanreotide, any of those, be used in combination together?
Yeah, absolutely. Absolutely. They can be used together. And, in the trials that we have done in the CABINET trial, we did have a number of patients who continued somatostatin analog therapy with TKIs. They can be safely combined. And especially for patients who have carcinoid syndrome, it's really important to continue the SSAs, and then you can add to it.
That's helpful. So going back to side effects, can TKIs cause bowel obstruction? Is there a risk of desmoplastic reactions with TKIs? And if you could explain what that is.
Exactly. Yeah. So desmoplastic reaction is often a process that happens. Many times it's with GI or sometimes even pancreas neuroendocrine tumors, whereas there's this fibrotic reaction that happens associated with the tumor. And it may be that the tumor is secreting growth factors that are stimulating some of the cells, what we call fibroblasts, to make a lot of, more fibrotic inflammatory products. And I think that sometimes that tethering process that can happen with these desmoplastic reactions can cause bowel obstructions. TKIs can cause bowel obstructions through their mechanism of actions, but it's not through that desmoplastic reaction that we see related to the tumor itself. So we would watch out, for instance, for symptoms of pain or nausea or vomiting that might indicate a bowel obstruction that could happen. I think all of the angiogenesis inhibitors, we are cautious when we use TKIs and medicines like bevacizumab in patients who are prone to bowel obstructions, because sometimes the bowel obstructions can happen. And if bowel obstructions happen and surgery is indicated, being on an angiogenesis inhibitor can complicate that surgical planning and decision making.
Things to consider in the decision making. Thank you for that. So I guess we'll close with this question. What advances in the NET field are you most looking forward to or most excited about?
Yeah, this is a great question. I think the field is certainly evolving, and I think we're making a lot of advances in large part due to research that's going on, in large part due to the clinical trials that are being conducted. I am really excited about many of the clinical trials that are ongoing that are looking at, for instance, some of the newer alpha PRT agents. We're also looking forward to presenting more final and more comprehensive results from the cabinet trial. But I think, what excites me about the field in general is the ability to do these clinical trials that are answering questions about novel treatment approaches, whether it be with a novel PRT approach or novel medical therapy approaches, because I think, again, these are important studies that'll help us to advance the field. And I think for our patients to be able to treat the disease better and to have more options to be able to consider.
Thank you so much. We really appreciate the opportunity to learn about treatment options for neuroendocrine cancer, and this presentation is especially timely given the positive results that you shared with the cabinet trial that you have been leading and that you dedicated so much of your own time and energy towards. So thank you again for all your dedication, hard work, and for all you do for the neuroendocrine cancer community. It's the dedication of physician scientists like you that give patients and caregivers like me, like us, hope. And hope is really what keeps us going. So thank you so much again, and we really appreciate all you do.
Oh, thank you so much. I was really glad to be able to join you today, and I'm, thankful for everybody's really great questions.
Yes, well, thank you, and I will send it back to Heather in the studio.
Thank you again, Dr. Chan, for your descriptive and insightful presentation and for answering so many important questions from our audience. We appreciate our supporters, Ipsen, ITM Pharmaceuticals, Tercera, and Crinetics. Again, educational programs like today's are made possible by donors like you as well. Please consider making a donation today at lacnets.org/donate. And a very special thank you to our technical director, Rich Tamayo from TVP Live, for this high-quality broadcast production. Today's presentation and Q&A session have been recorded and can be viewed on our website, video library, and YouTube channel shortly after this broadcast. Again, follow us on social media to stay up to date on our upcoming events. Our handle is @LACNETS. And now back to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Go to our website, lacnets.org, to find out more. LACNETS has a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the 10 questions we asked the expert. Thanks again for joining us for today's educational event. We look forward to seeing you next month. Bye.